Hello everyone. In our previous videos, we have presented cases related to gynecology. In this video, we are going to start learning cases which is related to obstetrics. This is our first case, which is about ectopic pregnancy. Let's learn more about ectopic pregnancy through a case. So our patient is a 27-year-old female. She attends the emergency department with irregular vaginal bleeding and abdominal discomfort. So about the bleeding, she noticed the bleeding 2 days previously and it is dark red, sufficient for her to need to wear a sanitary towel, but not heavy. The abdominal discomfort is suprapubic, which is just above the pubic bone, a few inches below the navel, and crampy slightly more on the right hand side. She is systemically well with no fever, change in appetite, nausea, or vomiting, and she says that her bowel and urinary habits are normal. Her last menstrual period commenced 45 days previously, and she usually has a slightly irregular cycle, bleeding for 3 to 5 days every 28 to 35 days. And she has never been pregnant. She has been with a regular sexual partner for 2 years, and they generally use physical contraceptives, but there are some occasions where they do not. She had a sexual health screen 6 months ago at the genitourinary clinic, where she was told all her swabs were negative, and she has no previous gynecological history and no significant previous medical problems. So, further investigations were performed, and on examination, her blood pressure and heart rate is pretty normal. The abdomen is soft and non distended, which means the abdomen is also normal. There is tenderness on deep palpation in the suprapubic and right iliac fossa regions, but no rebound tenderness or guarding. So, tenderness is observed on deep palpation in the suprapubic region, which is just above the pubic bone. Bimanual examination was not performed. Bimanual examination is the physical examination performed using both the hands, and it is usually performed to observe the women's pelvis size and location. Further investigations performed were urinary pregnancy test, which was positive, and transvaginal ultrasound scan was performed, and laparoscopy was also performed, in which fetus was observed, but it was seen in the fallopian tube and not in the uterus. So the diagnosis was made to be ectopic pregnancy since she has the classic symptoms of vaginal bleeding and abdominal pain. Plus, in transvaginal scan and in the laparoscopy, we could see the fetus present in the fallopian tube. There is no evidence of blood in the pouch of Douglas to suggest rupture of the ectopic pregnancy. In certain cases, when the ectopic pregnancy is quite severe or it has progressed, the fallopian tube or the region where the fetus is growing, which is outside the uterus, it could rupture, which is also called collapse. So, in cases of collapse, it is an emergency condition. And if a patient arrives in the emergency department with a positive pregnancy test uh, and other classic symptoms like vaginal bleeding, etc., she should initially be assumed to have a ruptured ectopic pregnancy. Classic symptoms of ectopic pregnancy are amenorrhea, iliac fossa pain, and dark vaginal bleeding. Ectopic pregnancies are, however, often diagnosed in women with any combination of symptoms from heavy vaginal bleeding with clots to period-type pain to no symptoms at all. So, in some initial stages where the embryo is very small, there might be no symptoms observed in the patient, but as the condition progresses, bleeding or abdominal pain could be observed. Let's learn more about this condition. Ectopic pregnancy is a complication of pregnancy in which the embryo attaches outside the uterus. In this image, the blue arrows point towards the uterus and the red arrows is pointing towards the fetus, which is developing outside the uterus in the fallopian tube. Conditions where the fetus starts developing in the fallopian tube instead of the uterus is also termed as tubal pregnancies. Signs and symptoms classically include abdominal pain and vaginal bleeding. but both the symptoms is usually not observed in the same patient. With very rare exceptions, the fetus is unable to survive. Overall, ectopic pregnancies annually affect less than 2% worldwide. Most ectopic pregnancies occur in the fallopian tube, which is known as tubal pregnancies. As we can see in this image, this fetus is developing outside the uterus in the fallopian tube, and almost 90% cases of ectopic pregnancy is tubal pregnancies. Detection of ectopic pregnancy is typically done by blood tests for human chorionic gonadotropin, also known as HCG, and ultrasound. So first, we need to confirm if the patient is pregnant or not. For that, a urinary pregnancy test could be performed, or blood tests for HCG could be done. And then to observe the location of the fetus, ultrasound can be performed. So if the fetus is seen in the fallopian tube, we can conclude that the patient has ectopic pregnancy. The standard treatment for ectopic pregnancy is a procedure to either remove the embryo from the fallopian tube or to remove the fallopian tube altogether. So in the initial stages, when the embryo is smaller in size, we can make an incision in the fallopian tube and remove the embryo without damaging the fallopian tube. But in much severe cases where the size of the embryo has increased, we might require to remove the fallopian tube altogether. Let's learn about the treatment and management of this condition. So, to treat or manage this condition, we can opt for either surgical or a pharmacotherapic method. So, in surgical methods, salpingectomy or salpingotomy could be performed. There is a difference between salpingectomy, salpingotomy, and salpingostomy. So, salpingectomy refers to the removal of one or both the fallopian tubes. It is performed in very severe cases where the fallopian tube has ruptured or it is severely damaged. In that case, fallopian tubes are removed along with the embryo. The difference between salpingostomy and salpingotomy is in both of these surgical procedures, there is an incision in the fallopian tube. Through this incision, the embryo is removed, but the difference is in salpingostomy, it is usually performed in more severe cases where the embryo might have ruptured or caused damage in the fallopian tube. So a different opening is created in the fallopian tube in salpingostomy. In salpingotomy, the incision is created, the embryo is removed, and then it is sutured back. In this case, the only option is surgical. Since this is a viable pregnancy, in viable pregnancies where the fetal heartbeat is visualized, it should always be treated surgically. The ectopic pregnancy should be removed laparoscopically. If the contralateral tube is healthy, then the tube may be removed. So if contralateral refers to the other fallopian tube which is not been affected, so if that tube is healthy, then the tube that has been affected could be removed. So after the surgical procedure is done, the patient requires certain counseling. So let's learn about patient counseling. So first of all, we need to explain the patient about the condition, how we did the diagnosis, and about the management. So for the diagnosis, we have to explain the patient about her symptoms, which is vaginal bleeding in this patient, and transvaginal ultrasound scan and laparoscopy also detected ectopic pregnancy. And we need to explain the patient about the surgical procedure. Avoid the progesterone-only contraceptive pill and intrauterine contraceptive device. Both these contraceptive methods have been shown to increase the possibility of ectopic pregnancy in women. So it should be avoided in this patient. And approximately 65 to 70% of women who have had an ectopic pregnancy go on to have a live birth following this. So in case the patient is scared of this procedure, or if she doubts about her second pregnancy or further pregnancies in the future, we need to assure the patient that in majority of the women, they usually have a live birth following this condition. And early transvaginal scan is indicated at around 5 weeks gestation to confirm the location of any future pregnancy. So, in case she has any future pregnancy around 5 weeks gestation, we need to perform a transvaginal scan to confirm the location of the patient, whether it is an ectopic pregnancy again or not. So that if it is an ectopic pregnancy, we need to manage it surgically or by pharmacotherapy. And in pharmacotherapy, we use methotrexate injections, which is given in early pregnancy. Methotrexate terminates the growth of developing embryo and it may cause an abortion. And surgical procedure, as we already learned, it's salpingectomy or salpingotomy, whichever is required in the patient accordingly. That's it for today's session. Thanks for watching. Please share this video and watch our other gynecological videos. Thank you.